Good afternoon, everybody. Thank you so much for joining us today. We are on episode 20 of Stewarts Soundbites, and we are in for a treat today. We've got Pankaj Madan, who is a barrister specialising in catastrophic injury work with us today. Hello, Pankaj.
Hello, Emma. Good to
Thank you
see
so
you.
much for joining us.
You're very welcome.
We've got a really interesting topic that we're going to chat about today. And I was saying to you before, Pankaj, before we started, actually, that doing Stewarts Soundbites is such a pleasure for me because week on week I get to learn all sorts of interesting new things. And I'm really looking forward to this because today we're talking about advancements in detecting traumatic brain injury. And the focus of it today is we're going to talk about subtle brain injury. And oftentimes, Pankaj, I don't know if this is your experience, but people associate subtle brain injuries with being very mild.
Yes, they do. They equate subtle with mild, and
Yeah.
I think they're exactly the same thing. But I mean, I think you and I have both seen many moderately severe to severe traumatic brain injuries, which in practice you might describe as subtle. But actually the brain injury is quite severe. And I think what we really mean is that subtle traumatic brain injury cases are those where the main effects are not completely transparent. They're not so much physical, that the victim can't walk, for example, or talk, but where the main effects are cognitive and emotional, and therefore upon casual observation or acquaintance, you may not realize immediately that the person is brain injured. But they can still be extremely serious, preventing the person working and needing even 24-hour support. So those are the sorts of subtle TBIs that I call subtle that I tend to be dealing with these days, as well as the catastrophic, which are obvious and of which we've had at least one recently together.
Mm-hmm.
So I think, yeah, that's what I would regard as subtle TBI these days.
Yeah.
They're certainly being challenged in that way by the defendants, who are doubting in many cases of severe brain injury the existence of the brain injury.
Yeah.
As they're entitled to do for us to prove.
Which is hugely problematic in the type of cases that we work with for lots of different reasons. But how can imaging, we're talking a lot about advancements today in imaging and testing, and how can imaging help us with a diagnosis of a traumatic brain injury?
Well, I suppose judges like what they can see, don't they? We all like what we can see, and it adds certainty. The differential diagnosis is normally between a psychiatric disorder and TBI, sometimes even malingering. So CT imaging, which will have probably been done in the hospital, will detect gross hemorrhages, but probably not the microhemorrhaging that we normally see with these types of brain injury. So in the A&E, why do they do a CT? Because it's actually not very detailed, as we'll see in a moment. Well, they do it because it's easy to access, and it excludes quite well a gross major bleed, which is going to lead to death early on. So it's to exclude those walk and die cases. It's the imaging of choice in the A&E setting. You don't have to worry about determining whether anyone's got metal in their body, for example. But of course, it's a high radiation dose as well. But it can't image white fiber tracts. It's not very good at detecting microhemorrhages, as I say. Well, what is the white fiber tracts? Well, it's the axons in the brain which are leaving the main cell body, the neuron, and traveling effectively to form interconnections with other neurons. And when they do so in large numbers, they form fiber tracts or bundles. And why might we get microhemorrhaging? And why is it important to show that on the imaging? Well, because the blood vessels are much tougher and much more fibrous and larger than axons. And we can image the blood vessels quite easily, even with standard MRI, or we can image bleeding, let's put it that way. But you can't image the axons themselves with standard MRI, and certainly not with CT. So if forces have therefore ruptured blood vessels, then because they're tougher, larger, and more fibrous than axons, then we can hypothesize that if blood vessels have been damaged, then axons have been damaged as well. So, but even regular MRI scanning at 2 Tesla, T2 level, will not be able to image bundles of white matter. But some imaging now is able to detect large bundles of axons or tracks which have been damaged. And that's the exciting aspect of it.
Mm. And what, I mean, generally speaking, I know that there are, with the methods that you've just mentioned, there are drawbacks and certain things that CTs just don't pick up on. But generally speaking, the scanning seems fairly advanced. And if it doesn't pick up on those smaller things that you mentioned, what is the problem with that, Pankaj? What's the issue?
Well, obviously, if scanning's not picking it up, then we're missing something. But there are even problems with the more detailed scanning, such as we can look at diffusion tensor imaging, which is a wonderful bolt-on to MRI scanning. And that's got some potential to evaluate subtle traumatic brain injury. But then you come across problems even with that. People such as Grant Iverson, who's a neuropsychologist in the United States, who I've seen speak in the UK, has been putting people through DTI scanners in the US for many years. And when they uncovered the blind, they found that those with symptoms, sometimes nothing had shown up even on the DTI scans. And conversely, people who were perfectly well, going about their normal daily business, had some positive imaging. In other words, you would expect them to be brain injured based on what was seen on the scan, and that wasn't there. So it's a bit like, I think, having degenerative changes in the spine. We're used to dealing with x-rays in spinal cases. And for example, if there's degenerative changes on the spine, doesn't necessarily mean that someone's in pain or that their pain is coming from those degenerative changes. So in other words, the correlation between what you see on the scans and symptoms is not always exact. So that's one of the problems.
Yeah. We always like to know on Soundbites, Pankaj, how many episodes you've seen, but we always like a little bit of insight into kind of the cutting edge of things. So maybe you could tell us a little bit more about the more advanced types of imaging that we can use to detect traumatic brain injuries.
Yeah. Well, first, let me tell you about the structural types. You've probably heard of SWI, susceptibility weighted imaging, which is a bolt-on for MRI. And what that does is look for hemorrhaging. And I've already set out the importance of why we might want to look for hemorrhaging, because it's indicative that if there's been a bleeding, then there's going to be brain damage. Now that's 3 to 6 times more sensitive than a conventional T2 scan. Then you've got quantitative susceptibility mapping, or QSM, and that looks more closely at the isotopes which have been left behind by bleeds, quantifies them in more detail, and reflects the spatial extent of the lesions in greater detail. Yeah, so those are 2 of the structural types. Well, the other types look for contusions. So they actually look for damage to the white fiber tracts themselves. So we've got 3D, T2 flare, and susceptibility weighted imaging, which also detect, you've heard of DAI, diffuse axonal injury. Here, what we're looking for is traumatic axonal injury. So diffuse involves at least more than 4 fiber tracts. And with traumatic axonal injury, we're looking for more major damage to 3 or less fiber tracts. So that's TAI as well as DAI. And so here we're looking for actual damage to the large fiber tracts, which is perhaps at the grey-white matter junctions where you get differing density of brain tissue. So TAI is actually thought now to be much more common than we thought it to be. The focus has been previously on DAI. We were blaming DAI for the symptoms. Well, TAI is now thought not to be limited to catastrophic cases where people can't walk and talk, but it's being linked to much more moderate or moderate severe injuries, and even mild. And we're seeing in the corpus callosum, which is that area in the center of the brain where you've got the crossover of the large bundle between left and right hemispheres of the brain. There's a thick bundle which crosses over. 22% of lesions being observed on these scans are in that particular area.
Wow.
And that's not surprising, because you've got the falx, which is runs right down. It's a cartilaginous tissue which runs right down into the central sulcus, and it's rather good at transmitting external forces directly into that center of the brain. And you may not get profound loss of consciousness either. So this is one of the areas which I think imaging could be really quite exciting if we're able to now image the large fiber tracts. DWI, you've probably heard of. That's sensitive, particularly in the acute to early stages of injury. It's diffusion weighted imaging, and that looks at the microscopic motion of water molecules in brain tissue, because water molecules flow much easier along fiber tracts which are undamaged because they're straight. And when they get disrupted, you get disruption of the diffusion of water molecules, and you can measure that, and then you can see what the damage to the fiber tracts is.
Really
So that's how it's doing it.
It's
Fascinating.
it's amazing, isn't it? I
It
mean,
is.
you've already mentioned this, Pankaj, but I'm interested to know a bit more about it. You mentioned diffusion tensor imaging.
Yeah.
Can you tell us a wee bit more about that? And I'd be interested to know whether there are any problems with that, of making use of that in a medical legal context.
Well, finding somebody who'll do it, first of all.
Yeah.
David Sharp, Hammersmith Hospital and Imperial College, has got the ability to do it. Whether he will do it for you or not, I don't know. The Walton Centre, I think, has also got the ability to do it. I've used it in a couple of cases. So it's got the enhanced ability to track that direction of water molecules in 3D space. Mm-hmm. So in normal white matter tracts with the parallel fiber bundles, water diffuses smoothly along the direction of the white fiber matters, and then it diffuses with more difficulty transversely. So normal undamaged white fiber tracts exhibit highly directional diffusion, whereas damaged white matter tracts demonstrate more isotropic diffusion because of the perhaps, and this is a theory I believe, through the lack of longitudinality in the microstructural elements which have been damaged by the trauma. So DTI is a marker for the white matter pathology, including traumatic brain injury. So we can actually produce, or the neuroradiologist can produce for us, rather interesting pictures of perceived damage to the brain. It looks like you're seeing it with your eyes, the brain with your eyes, but actually it's been generated by computer as a result of what the way the water molecules are diffusing. So shall we, if I just share my screen, I can show you a few of the different types of scan.
Yes, please, that'd be great.
So if you can see that, can you see that?
Yes, yeah.
So on the left, you've got a T1 type scan, yeah? So a 1 Tesla scan, and then you've got a flare sequence. But then if you look here on the susceptibility weighted imaging sequence of the same brain, you can actually see a marker of the traumatic brain injury here.
Wow, it's really remarkable, Pankaj, isn't it?
It's fantastic, isn't it? And then if we go on to DTI, wait for this. This is literally quite mind-blowing, because what you're actually looking here at are the damaged, or the perception, the computer-generated image of the damaged white fiber tracts, which are highlighted in red.
Wow.
And you can see they're actually in quite a lot of the deeper structures of the brain. So this idea that brain injury is confined to the surface or the surface bruising is just wrong.
Mm. Wow. And so often we see, don't we, someone's had a CT scan and it's all clear and they say the CT's fine, there are no problems, you know, and it's those type of images just really are so remarkable. And I know that you wanted to talk about some other types of advancements and different types of scanning. I know some of them are not technically scans even.
Well, DTI, well, let's just finishing on DTI. Many say it's not ready for medical legal use. So, but I mean, I have had it done. It is a bit controversial. So what's coming, I think, could really fill some of the gaps. So we've got MR spectroscopy, MRS, which is similar to MRI. Certain markers are released after TBI. I know Ben Townsend tells us about the blood tests which are now being done in A&E settings, or able to be done in A&E settings, and that's very exciting. And that, of course, that will tell us whether there's a brain injury, but not whether initially, but not whether the cause of any continuing symptoms is the brain injury. So, but MR spectroscopy is really exciting because these markers can remain elevated and be detected even at later stages. One of the problems with MRS, however, is it's not always specific to TBI. You can get these markers with other brain conditions, but it can still be very helpful. Then you've got perfusion weighted imaging, which looks at blood flow and blood volume. And then you're getting towards functional MRI. Now, functional MRI scans, you can literally see different areas of the brain light up in accordance with different tasks that the person is trying to do. So imagine combining that with neuropsychometric testing and seeing how the brain responds. That's where I think we're heading. And one of the latest, let me share my screen with you, and I'll show you some images of functional MRI. So here, can you see that, Emma?
Yeah.
You've got the sensory cortex lighting up here for right palm touch, or word generation, and you can see which areas of the brain are lighting up. So really quite fascinating.
That's functional
Basically,
MRI?
functional MRI. And people are using, I also do a lot of pain cases, and you can use functional MRI to show the pain centers lighting up. So it's going to have the 7 different pain centers in the brain where pain is processed. So there is this link between pain and brain injury as well, because obviously it's abnormal pain perception that you're dealing with in pain cases, severe pain cases. But then you asked about what other techniques. I mean, this isn't technically imaging. Magneto encephalography is very exciting, and I think that's where it's going. We're essentially going to be combining structural information and electrophysiological information together. So MEG, MEG, combines functional MRI and EEG, the electroencephalogram, and it's going to be able to detect, we hope, abnormal connectivity after traumatic brain injury, even in patients with mild and subtle traumatic brain injury. So we're going to be giving or measuring activity, giving the claimant tests and measuring activity on, for example, neuropsychometric tests, and being able to look in real time at the working of the brain and how it's actually processing and working. And that is going to take a lot of the doubt, hopefully, out of this area. It's not quite ready for medico-legal use, but I think it will be within a few years.
They're not some of the things that you've mentioned, in the medical legal world, they haven't popped up yet. So we've got to bide our time.
I think this is a very exciting area to be working in.
Yeah, for sure. Oh, I have a million questions, Pankaj, that I want to ask you. And if I opened up the Q&A, I think it would be frantic. But unfortunately, we're out of time. As always, it comes far too soon. But that was absolutely fascinating. Thank you,
Emma.
And
great questions.
Well, thank you so much for your time, Pankaj, and I hope you don't mind me saying that you are on Twitter, as am I, and you are a great tweeter. And if people find you on Twitter, they'll probably find some really interesting stuff on there. And maybe Pankaj, you'd be happy to pick up any questions at the from this session. So if anybody does want to ask anything, please do get in touch. You can get in touch with Pankaj via Twitter, is probably easiest, or with me via email. You probably all have my email address, so feel free. And thank you all very, very much for joining us today. And thank you again, Pankaj. That was absolutely
Thanks for asking me, Emma.
No, it's a pleasure to have you. Next week, we have a really good session coming up. We're going to be talking about CHC funding, a bit of a guide to CHC funding. So we hope that you'll find that interesting, and we'll see you next Wednesday at 1 o'clock. Thank you.